it's really, to this day, a tremendous workhorse in our practice, and just going to kind of go through how we utilize this technology really on a daily basis, and even to the point where how we designed our practice was based on the fact of how much we're utilizing this device. So the figure on the left is the room on the very end on the figure on the right. So I'm showing you these sliding doors just to tell you we're having so much fun that we wanted to have access from the other rooms, and we're doing a combination of treatments. So we wanted to give the patients, especially when the other take-home point here is this technology was really the first to allow us to resurface off the face because of the fractionated mode of delivery. So we have patients who are disrobed, and we want to maintain their privacy, and so this is allowing us to do that. And again, the best approach is achieved with a combination of treatment methods. So that's how we set up our practice accordingly. And I just put this slide in just to show the versatility of this technology, and I'll explain why this technology is so versatile in the coming slide. But in terms of what we're going to be talking today in the time that we have is the predominantly, obviously, superficial rhytids. The scarring is really how it's revolutionized our practice: acne scars, surgical scars, burn scars, dyschromia, and then, unfortunately, we use it a lot to address complications from from the community that we're unfortunately seeing more and more of, and we'll hopefully show that at the end, how we utilize this technology to correct complications that are induced by other laser technology. And Dr. Davis did a good job of overviewing this. I would just say that, point 5, just the importance that this technology allows us to combine it with other lasers to enhance efficacy. And I like the analogy that was used earlier at the meeting, that the carpet bombing, how we're kind of aerating the lawn with this pixelated mode of delivery. And it's just really revolutionary. I think all of us take it for granted, especially some of our early career members. But this is what really stood with me in terms of how I utilize this technology. And I show it in every fractionated talk I give. This was by Dr. Hantas. And this was the first study to show that we have the ability to eliminate dermal content utilizing this technology through the weakened DE junction. So the pink arrows are on dermal elastin, and the red arrows are showing it being extruded through the weakened DEJ junction. That's elastin content. So this was the first time we had the ability to utilize a non-ablative laser to target extracellular dermal material. So why is that relevant? Well, that opened up everything. So now all of a sudden we have a technology that can allow us, such as in this case that we published, a patient with lichen drug eruption, lichen planus-like drug reaction from a hypertensive medication, who was prescribed multiple topical medications. They did not resolve with discontinuation of the medication. And we said, you know what, let's give it a try. And so what we do is we combined it with, in this case, it was topical cysteamine. And we use that a lot in patients with skin of color, and then to pre-treat the skin, take it as far as we can. Obviously, you want to control any inflammation as well, get this lesion as static as possible. And then we intervene, and then as Dr. Davis mentioned, we use low energy, low density. We don't want to do anything that's going to further exacerbate it, but we basically want to just gradually eliminate this pigment over time. And you can see the nice results 3 months after 5 treatments, and she's so happy she still comes in for further improvement. And we've published on the role of combining non-ablative fractional technology with various low molecular weight compounds, and our favorite is topical bimatoprost, especially for hypopigmentation or hypopigmented scars, and we'll talk about that as we get further in the lecture. So this is a paper we published in 2010, and it's, for those of you who haven't seen it yet, it was a consensus paper of various, at that time, physicians from around the country, with just the 1550 wavelength. And so again, I think we all, just giving a little bit of history, the 1927 wavelength wasn't available until, I believe it was 2008. So this was a paper just looking at the 1550. And I think what's so revolutionary for someone who, for our practice being in Houston, where it's so ethnically diverse, is our ability to treat all skin types with this wavelength has been revolutionary in terms of the number of conditions that we can target. And what we pointed out in this paper is our ability to target patients with darker skin by utilizing lower densities to minimize the disruption of the DEJ junction. Now, you'll see melasma in there, and I teach my fellows, and for those of you who work with me, I mean, you'll see that that's not something that, in my opinion, is definitely not first line or second line. It does have an FDA approval, but I think what a lot of us who were utilizing it early on found that you had some early improvement, but then you had that rebound risk. And so there's newer technology that have lower energy, lower density that we'll talk. Well, I don't know if we're going to talk about it, but I would just say I would gravitate towards those devices, at least initially. This is non-CME, right? Okay, so the one device is the Clear and Brilliant. So it's kind of, we call it like a mini fractionated device, lower energy, lower density, and you can't get the same effect by just turning this laser down, because there's a difference in the beam profile. So for those of you who are considering new devices, you choose based on the patient population and the most common conditions that you're going to be seeing. Now, Dr. Abrams' group published this paper, and this is something that really comes up every day, and this is probably something that all of us up here were aware of in our clinical practice. And what we were observing over the course of 20 years is that patients who had a history of skin cancer, as they were going through these treatments, were developing noticeable less skin cancers. And so to have a study like this really validated, and I think it's really telling, practicing in Houston next to MD Anderson, which is the #1 cancer center in the world, patients are being referred over for this. I mean, I still am a big advocate of photodynamic therapy and topical chemotherapy, but it's not practical for everyone. And I don't recommend this as a single modality, but as over the course, and Dr. Tansey, I'd love to hear your opinion, over the course of a lifetime, if you can have a treatment once a year, and that's the pearl I would pass on, that's what I personally do, and I tell patients that. I try to get one treatment every year just to slow the aging process. And this is an additional benefit for patients, chemo preventative for patients with a history of skin cancer. Dr. Davis covered a lot of this. I would just, again, practicing in a very ethnically diverse population, we see a lot of patients with skin of color, and I just assume everyone has subtle melasma. At this point in my career, I assume everyone has it until proven otherwise, and I treat accordingly. And so how do I do that? Well, the first thing I do is I image them. And the next pearl I will give is you're only as good as your baseline photographs. So if you're going to be doing this, take standardized, reproducible photographs. Make sure your staff is trained, because that's from moving forward. As soon as you intervene, that's going to be what's going to be your standard in terms of conveying to patients their improvement. Topical anesthesia is shown, and then the nitrous oxide has been a game changer for us as well in terms of patient comfort, and I'll talk about another modality that we're now using in our practice that's really helped with patient comfort. So I'm just going to share an example of the photography. This is the Visia system, and it allows us to visualize epidermal, and it also has an ability to visualize dermal melanin. But in this study from Dr. Nagishi, as you can see the subtle melasma, and so we're literally staring at these images before we do any treatments, and it guides us in terms of the treatments settings that we're going to be utilizing, because if you exacerbate a subtle case of melasma, you're going to have a very unhappy patient. Another pearl I would say is have these types of images in your exam rooms. The company will provide this. It's very helpful for patients to be able to visualize the healing sequence. This is a typical healing sequence in a Fitzpatrick skin types 1 through 3, so they can understand with the 1550 wavelength the type of erythema and edema, and they can plan accordingly. And we find this very useful during the consultation process. I can name names, right? So I'm going to say TouchMD has an excellent system that we use during our consultations, and we have these treatment diaries before and after. All these images are on these monitors in the exam rooms, and the patients find them very useful. So just to give you show some examples of various conditions, and I put the settings in there for y'all. Periorbital rhytids with excellent improvement after 3 treatment sessions. This was something we were very happy and kind of surprised. Our goal was to target the skin laxity, and We found that there was improvement of the dyschromia as well. So we all have these patients coming in with complaints of periorbital, or what they refer to as dark eyes. And so, I mean, we could spend an hour just talking about the etiology of that. So you obviously want to determine whether it's vascular or volume loss, but oftentimes it's pigment. And so, we obviously will pre-treat to maximize the effect, to suppress the melanocytes and target any epidermal melanin. But then you can achieve these types of results for dyspigmentation. Of course, you want to make sure you're cooling the skin properly, and we'll often prescribe topical skin brighteners during the recovery process. And then just kind of going off the face, this is an example of the neck that we published in that consensus paper. Nice improvement after 4 treatment sessions. And then the 1927 wavelength, as I said, was then subsequently introduced, and that's really been a game changer. And I think, I show this diagram, just even though it's a longer wavelength, you get more water absorption at the 1927 wavelength, so it's not going as deep. So it's indicated for more superficial indications, such as tone and texture and pigmentation. And so we did a secondary consensus paper with some other physicians. This was during COVID, and what struck me the most during this consensus panel was how excited everyone was about the 1927 wavelength, because I'm such a big advocate of the 1550 wavelength with all the patients of skin of color that we treat. But the 1927 wavelength really is a remarkable wavelength for achieving these types of results for patients with lighter skin and various types of dyschromia. It's hard to visualize, but this patient had some AKs as well, and this is where you can see improvement of the overall texture, and we also published on the improvement of AKs, but then we did histological analysis and saw some residual. So again, I never recommend this as a single modality, often in times with topical, either a chemotherapy or sometimes we'll do liquid nitrogen on the same day if we see any AKs. But more and more patients are being referred since Dr. Abrams' paper for this chemo prevention effect. And there's just some more before and afters following 1927 thulium fiber laser. And then just another clinical pearl for lighter skin types. These are the total kilojoules that we're typically utilizing. And I think this cannot be emphasized enough. I mean, and I think this is something that behooves us when we're at a meeting like this, is you have people presenting the various data, but we need to know the total kilojoules that are being delivered so we can standardize our care. And so I think that's something that's incumbent. And again, for patients with Fitzpatrick skin type 4, this is from the company. I think this is, in my hands, it's a little aggressive, but I just show it just to show how the typical healing sequence and the excellent results. For those of you who are new to this technology, I would start much lower in terms of the coverage. We typically would start more along the lines of 30% coverage in this skin type. And as was mentioned earlier, with patients with Asian skin types, we're going to decrease the density to reduce the risk of PIH and decrease energy, and then the cooling is important. We actually have a Zimmer device that we have the patients either hold or a nurse administer, especially when we want to make sure for patients where we're worried about PIH, we want to make sure that we're cooling the skin. And then now again, moving off the face, when you're using the 1927 thulium on the chest, you also want to be very careful. We always ask patients, do they have any pets at home? Because we all love to bring our pets close to us. And you can get, I think we take for granted the safety of this technology, and but when treating off the face, you still want to be mindful of the risk of infection and counsel patients on appropriate post-op care. I'm going to move along because of time. I love to combine the two wavelengths, so this is something that I do. I think there's a synergy between the two, and so we'll often use the 1550 first and then follow up by the 1927. There's examples on the neck and the chest. I really want to get to my scars, so I'm going to just keep moving. Excellent results for dyschromia on the chest, but again, you want to start very slowly because you don't want to induce further PIH. And then this is just showing how we'll combine it with pulse dye laser to target underlying telangiectasias. So these are some additional pearls in terms of for post-op care, cooling gel, mask. We're going to talk about global cryomodulation and the role that that's played in our practice in combination with this modality. I would just reemphasize low potency steroids we utilize for patients with skin of color and a topical skin brightener, and then sunscreen. And there's been a great abstract at this meeting on the roles of using physical blockers as well. So this is something that we've been doing over the last year. It's a device developed by Dr. Rox Anderson that uses precise cooling to achieve desired effects, and we're using cooling to reduce some of the inflammatory effects of the laser. But not only is it helping with the recovery process and the associated pain and discomfort immediately after the treatment, but I believe that it's helping with the efficacy of the results. And we're at about sub-zero degrees, and this is the device. It's a 10-minute procedure. We're doing it right after our fractionated treatments. Patients love it because it's extracting heat, it's cooling the skin. It almost has a spa-like effect. And I can tell you, patients who, once you've had it, they've had it, and they've had treatments without it, they want to continue to it's just, we do an additional charge, but they don't think twice about it because of the recovery is quicker, as shown by this paper that we published with Dr. Murray, which showed that there was reduced pain, reduced swelling. In this study, you can see on the treated side, reduced erythema and edema at 2-day follow-up. I got to keep moving here. Just to further emphasize the point of combination treatment, we often do fractional laser and light treatment on the same day, utilizing the synergy that we can achieve utilizing the microscopic columns of pigment that result from fractional laser treatment enhances the ability of using Q-switched or picosecond lasers, and I think this is a great demonstration of that, where we're able to achieve almost complete clearance following one treatment session with 1550 and followed by Q-switched alexandrite laser. Patient with hemosiderin deposition and other signs of photoaging before and after 2 treatment sessions with pulse dye laser, non-ablative fractional resurfacing, and the Q-switched alexandrite laser. And then showing combination with the Q-switched Alex for dyschromia. And then in the remaining time, I want to just talk about scars. Again, we often use a variety of different modalities on the same day with various types of medications. This is an algorithm that I published with Dr. Kavar. This is a very good reference talking about how we categorize the scars, and then that'll guide us in the therapy that we deliver. And this is the consensus paper that I published, referenced earlier, that shows nice improvement of post-inflammatory erythema and acne scarring, 1550 non-ablative fractional resurfacing after 6 treatments for post-inflammatory erythema and acne scarring. Again, the value of this laser in my patients of all skin types cannot be underemphasized or overemphasized, I'm sorry. This is a very challenging condition, and we were able to also address the DPNs utilizing light pinpoint electrodesiccation. Burn scars, we utilize this routinely, 1550 wavelength. Again, atrophic burn scar and Fitzpatrick skin type 6, nice improvement. And then combining it with the pulse dye laser for another burns, residual hemangioma, and then 1550 wavelength for stria on the chest, atrophic scar with associated erythema with just 1550 alone, post-inflammatory hyperpigmentation, and then hypopigmentation associated with acne scarring. And then just want to wrap up how we utilize this technology to correct complications. These are coming in from plastic surgeons, from med spas, and I think if we can just do one thing, that would be to educate our colleagues on the importance of early intervention. We can achieve these types of results. Lip retraction from a phenol peel, and was not referred to her as the patient found us through her Mohs surgeon. She was told that she was going to need a skin flap or nasolabial repair, and obviously that's not true. We were able to achieve these types of results with 1550 non-ablative fractional and pulse dye laser. Hypopigment. This woman, they injected fat into her face. Injected a corticosteroid into her face, and you see the atrophic scar that resulted. We corrected with 1550 and topical bimatoprose. And then hypopigmentation from laser tattoo removal. So we do the laser, actually do the 1550 first, and then to correct some of the hypopigmentation and scarring, and then we followed with, in this case, the 1064 and 785 picosecond to address the residual tattoo. This patient was burned also at the hands of a physician. I think they utilized, I don't know, an IPL, and significant improvement. And I think the key here that we achieve these types of results is because we intervene so quickly. Dyschromia following laser hair removal at a med spa corrected with the 1550s. So thank you very much.